If you are a plastic surgery resident preparing for your board exams, stop whatever you are doing and head over to medsynclimited.com right now.
Yes, absolutely. Do that right away.
You need to get the FRCS Plastic Surgery ANKI deck.
It is a total game changer for revision.
It really is. It contains over 7,000 questions arranged by topic.
Right, which turns your passive reading into active recall.
Exactly. And it is based entirely on the textbook keynotes in plastic surgery.
So it is essentially your ultimate go-to revision companion.
Go to medsynclimited.com to grab that. Now, welcome to this special mock exam deep dive.
We are going to be jumping right into the fire today.
No fluff, no long intros.
Yeah.
Our mission today is to hit you with high-yield clinical scenarios for the FRCS.
So put yourself in the hot seat. You are in the exam room right now.
All right, let's look at our first patient.
Uh-huh.
We have a post-operative trauma scenario.
Very common setup for the board.
Yeah. So you've just finished a surgery to reduce an open tibial fracture with skin loss.
Okay, major trauma.
Right. And the patient is back on the ward, well hydrated. There are no constricting dressings anywhere.
That's a key detail to note.
Yeah, but suddenly his foot pulses, which were totally fine before, are now completely impalpable.
Oh, that is a terrifying moment for any resident on call.
Seriously. So the board exam gives you 5 options for your next step.
Let's hear them.
We have catheter angiography, estimation of digital toe pressures, a handheld Doppler examination, measurement of compartment pressures, or magnetic resonance angiography.
Okay, so this is a classic hierarchy of diagnostics question.
I mean, my immediate physiological panic response is that the tibial artery is blocked or torn.
Right, vascular compromise.
Exactly. So my gut says wheel him straight to the angio suite for catheter angiography. I want to see exactly where the problem is.
And that is exactly the trap they're setting for you.
Wait, really? It's a trap?
It is the ultimate trap. Look, you are totally right that catheter angiography is the gold standard for mapping the vessels.
Right. It gives you the perfect anatomical picture.
It does, but in a surgical algorithm, invasive diagnostic procedures always have to follow non-invasive confirmation.
Oh, I see.
Yeah, so when you lose a palpable pulse in a post-op limb, your first question shouldn't be, where exactly is the tear?
So what should I be asking?
You should be asking, is the pulse actually gone, or is my hand just failing to feel it through the swelling?
Right, because postoperative edema can make pulses super hard to find.
Exactly. You do not subject a stable patient to the risks of a contrast dye injection and an arterial puncture just because a pulse is hard to feel.
That carry a real risk of contrast-induced nephropathy, right?
Yes, it does. So the correct answer here is a handheld Doppler examination.
Ah, okay. The Doppler on the ward trolley.
Exactly. It uses ultrasound to detect the frequency shift of the red blood cells. It takes 30 seconds at the bedside.
And it tells you right away if there is flow or not.
Right. It instantly differentiates between a pulse hidden by edema, where you'll hear a clear whoosh, and a true mechanical occlusion, where you just hear silence.
That makes perfect sense. It's like trying to check the water pressure in a house by ripping out the drywall to inspect the pipes.
Yes, exactly.
I wouldn't do that before just turning on the kitchen sink first to see if water comes out.
That is a perfect analogy. You establish the deficit before you hunt for the anatomical location.
But let me push back on one of the distractors here. What about measuring compartment pressures?
Compartment syndrome. Always a worry with tibial fractures.
Right. The leg has all those tight fascial compartments. The trauma plus the swelling is the perfect storm for tissue pressure to spike.
It is, and that is why it's a brilliant distractor. But the pathophysiology doesn't match the clinical vignette.
How so?
Well, compartment syndrome is not initially a disease of the large arteries. It is a disease of the microcirculation.
So it affects the capillaries first.
Exactly. The pressure collapses the thin-walled venules and capillaries. The arterial blood keeps pumping in, but it can't drain out.
Which causes the massive swelling and agonizing pain.
Right. But the main arteries, like the tibial arteries, have thick walls and high pressure. They stay open until the very, very late stages.
Oh, so if the pulse is gone because of compartment syndrome, you are way too late.
Yes. You have missed the boat by several hours. The limb is probably already necrotic.
Wow.
Plus, the stem says the patient is well hydrated and stable, and it mentions absolutely nothing about intense pain on passive stretch.
Which is the hallmark sign, right?
Exactly. You don't stab a striker needle into someone's leg based purely on a missing pulse. You use the Doppler first.
Okay, moving from trauma to a strict hierarchy of tissue survival, here is our next patient.
Let's do it.
We have a 45-year-old in the outpatient clinic with maturing burn scars. Huge surface area.
Okay, where are the burns?
They affect the hands, the upper limbs, the neck, the side of the face, and the eyes.
That is a very complex clinical picture,
It really is. So he has severe hand contractures, limiting his daily activities.
which is functionally devastating.
Yeah. But he also has bilateral upper and lower eyelid ectropion from the facial scarring.
Ah, ectropion, that changes everything.
Right. So the exam asks for the absolute surgical priority.
Okay, what are our choices?
Facial resurfacing, release of the hand contractures, release of neck contractures, release of upper and lower eyelid contractures, or steroid injections.
Like, what is your gut telling you?
Well, my human instinct looks at a 45-year-old who can't use his hands and thinks about his livelihood. He needs to feed himself and work.
It feels like the hands should be the priority, functionally speaking.
Yeah, exactly. But the face is involved. So what actually dictates the surgical priority here?
The difference between a functional deficit and a catastrophic, irreversible organ loss.
Okay, organ loss.
The undeniable priority here is the release of the upper and lower eyelid contractures.
Gives it the eyes.
Right. In plastic surgery, especially burn reconstruction, organ preservation and vision will always supersede functional limb improvement.
And both of those outrank aesthetic stuff like facial resurfacing.
Always. To understand why the eyelids trump the hands, you have to look at the biomechanics of a burn scar.
Right, the myofibroblast pulling everything tight.
Exactly. They deposit dense collagen and contract like a purse string. When this happens on the eyelid, the scar pulls the lid margin away from the globe of the eye.
Which is an ectropion.
Yes. And with bilateral upper and lower lid ectropion, the patient physically cannot close their eyes, even when they sleep.
That's logophthalmos. And when the eyelids can't close, the cornea is just constantly exposed to the air.
Precisely. The cornea has no blood supply. It relies entirely on the tear film for oxygen and lubrication.
So the tear film just evaporates.
Rapidly, the corneal epithelium desiccates and breaks down, creating an ulcer.
And then bacteria can get in.
Right, microbial keratitis. And if that ulcer goes unchecked, the enzymes literally melt the stroma until the globe perforates.
Oh, wow, that is terrifying.
It leads to endophthalmitis and permanent, irreversible blindness.
So you simply cannot wait on the eyelids.
You can release a severe hand contracture 6 months from now and still get a great functional result with physio. But if you wait a month on that eye, they are blind forever.
Sight outranks grasp.
Always.
That makes the hierarchy undeniable.
Yeah.
All right, let's pivot to pediatric craniofacial anomalies.
I love these cases.
We have a 2-month-old infant in the clinic. You get a 3D craniofacial CT scan.
Okay, what does the radiologist see?
They note a distinct elevation of the superlateral corner of the orbit.
Ah, the classic Harlequin sign.
Exactly. So the options for the most likely diagnosis are deformational plagiocephaly, hemifacial atrophy, hemifacial microsomia, tessue 10 cleft, or unicoronal synostosis.
Okay, let's break this down.
While I know a lot of babies have asymmetric heads from sleeping on their backs, deformational plagiocephaly is super common.
It is incredibly common, but a specific orbital bone elevation feels like a structural skeletal pathology, not just positional flattening.
Right, so we are looking for a failure of normal bone growth.
Exactly. And the correct answer is unicoronal synostosis.
Okay, let's talk about why we see that Harlequin sign,
You have to understand Virchow's law of cranial growth.
which is about how the infant skull expands, right?
Yes. The newborn skull is a mosaic of bony plates separated by open, fibrous sutures.
Like expansion joints for the growing brain.
Precisely. As the brain rapidly expands, the bones grow outwards at these open sutures. Virchow's law states that if a suture fuses prematurely,
That's cranial synostosis.
right, growth is completely arrested in a direction perpendicular to that fused suture.
So the skull has to compensate by growing excessively parallel to it.
Yes, to make room for the relentlessly expanding brain. In unicoronal synostosis, one of the coronal sutures fuses prematurely.
So if the right coronal suture fuses, the right side of the forehead just stays flat.
Yes, it can't grow forward,
Ah.
and the left side bulges out to compensate.
But how does that affect the eye socket? How do we get the Harlequin appearance?
Because the coronal suture doesn't just stop at the top of the head, the fusion process extends down into the skull base.
Oh, into the sphenoid bone.
Exactly. The lesser wing of the sphenoid forms the posterior part of the orbital roof. When the suture fuses, it tethers that bone.
So the normal forward growth is stopped, and the sphenoid is pulled upwards toward the fusion.
Yes, so on a 3D CT, the normal orbit looks fine, but on the fused side, the superior lateral roof of the orbit is sharply angled upwards.
And it looks exactly like the slanted eye mask worn by the Harlequin character in theater.
Pathognomonic for unicoronal synostosis.
That is fascinating. But let's quickly touch on hemifacial microsomia as a distractor.
Sure. That is a congenital anomaly affecting the first and second branchial arches.
So you get underdevelopment of the jaw, the ear, and the facial soft tissues on one side.
Right. The face is severely asymmetrical, but it is a problem of hypoplasia, a lack of tissue volume.
It's not a premature bony fusion.
Exactly. It does not cause that specific superior lateral orbital pull. The Harlequin sign is a vector of fusion, not underdevelopment.
Okay, let's jump from infant skulls to an adult outpatient clinic.
A different kind of tissue proliferation.
Yeah. We have a 28-year-old man with a 12-month history of symmetrical breast enlargement.
Okay, gynecomastia.
But here is the crucial physical finding. The breast tissue is distinctly tender to palpation.
Oh, tender. That is the magic word in the stem.
And his BMI is 26.
Mildly elevated, but not massive.
Right, so our options are ACTH deficiency, a drug side effect, ductal carcinoma in situ, Klinefelter syndrome, or obesity.
Well, my immediate thought process goes to his weight, right? A BMI of 26 is overweight.
Sure, and adipose tissue contains aromatase, which converts androgens into estrogens. More fat equals more estrogen.
So why shouldn't we just say this is obesity and tell him to lose weight?
Because the clinical exam is screaming at you that this is not just passive fat accumulation.
Right, the tenderness.
Exactly.
Yeah.
Gynecomastia is the benign proliferation of male breast glandular tissue. When it's just from obesity, we call that pseudogynecomastia or lipomastia.
Which is just stromal adipose tissue.
Right. Fat deposition is slow, insidious, and overwhelmingly painless. It is not tender.
So if it's tender, what does that mean on a cellular level?
It means there is active, acute inflammation or rapid proliferation of the glandular ductal epithelium.
It means his breast tissue is being bombarded by a sudden shift in hormones.
Right. An acute shift in the ratio of free estrogens to free androgens. You wouldn't see that just from a BMI of 26 in a healthy 28-year-old.
It would be physiologically baffling.
So if tenderness rules out slow fat accumulation, we have to look for an acute disruptor.
Which brings us to option B, a drug side effect.
What kind of drugs are we talking about in a 28-year-old male?
The absolute first suspect you must tactfully rule out is the use of anabolic androgenic steroids.
Bodybuilders.
Exactly. When a young man injects massive doses of synthetic testosterone, his hypothalamus senses the overload and completely shuts down natural production.
It stops releasing gonadotropin-releasing hormone.
Right. Which shuts down LH and FSH from the pituitary. So his natural testosterone drops to zero and his testes atrophy.
But he still has all that synthetic testosterone floating around, right?
Yes, and much of that massive dose gets peripherally converted by aromatase into estradiol.
So you have a huge spike in estrogen and no natural testosterone.
Exactly. The breast bud is intensely stimulated, causing rapid, painful glandular growth.
But it's not just steroids, right? What about prescription meds?
Oh, absolutely. Finasteride is incredibly common in 28-year-olds for male pattern baldness.
Right. It inhibits 5-alpha reductase.
So testosterone can't convert to DHT. The excess testosterone pool gets shunted down the aromatase pathway instead.
Which again leads to excess estrogen and tender gynecomastia.
Exactly.
But what about Klinefelter syndrome? That's a classic board exam cause of gynecomastia.
It is. Klinefelter is a 47,000 XXY karyotype. It causes primary testicular failure.
So you get high estrogen and low testosterone.
Yes. But look at the clinical timeline here.
He's 28.
Right. A patient with Klinefelter syndrome does not suddenly wake up at 28 with his first symptom being isolated, tender breast tissue.
Because it's a chromosomal issue, it would show up during development.
Yeah, exactly. It presents with a history of delayed puberty, unicoid body proportions, very small tests, and infertility.
He would have known something was wrong a decade ago.
A drug side effect is the only logical explanation for acute, tender onset at age 28.
Okay, let's move to a scenario where the anatomy itself is hiding from us.
This is a great cleft case.
We have a 12-year-old girl in the clinic. She has a long history of hypernasality in her speech, and fluid sometimes comes out of her nose when she drinks.
So we suspect a submucous cleft palate?
Yes, but specifically an occult submucous cleft palate.
Okay, occult is the key word.
Exactly. The exam wants to know the best modality to diagnose this anatomical defect.
What are the options?
A full speech evaluation, electropalatography, lateral video fluoroscopy, MRI, or mesendoscopy.
Let's establish the baseline first. How do we diagnose a standard non-occult submucous cleft?
Clinically, just by looking in the mouth. You look for the classic triad.
which is a bifid uvula, a translucent bluish zone down the midline, the zona pellucida.
Meaning there is no muscle underneath.
Right, and if you run your finger along the roof of the mouth, you can palpate a bony notch in the hard palate.
But this is an occult cleft. Occult means hidden.
It is a masterclass in anatomical deception. If you ask this girl to say, ah, you will see a perfectly normal uvula.
And a thick, pink mucosal surface.
No translucent zone at all. It looks entirely intact from below.
But the pathology is deep in the muscular layer.
Yes. The normal soft palate is a muscular sling, mainly the levator villi palatini muscles.
They lift the palate up and backward against the pharyngeal wall to close off the nasal airway.
Exactly, which prevents that hypernasality. But in an occult cleft, those muscles fail to meet in the midline.
There is a muscular diastasis.
And frequently, the musculus uvulae is just completely absent. But because the oral mucosa is thick, you can't see the missing muscle from the mouth.
So if we can't see it looking up from the mouth, we have to look down from the nose.
Which brings us to nasendoscopy.
Right, you pass a flexible scope along the floor of the nasal cavity.
The mucosa on the nasal side is much thinner. You can literally see the anatomical depression in the midline where the muscle should be.
You can watch the muscles contract and clearly see the failure of the central sling.
It provides a direct anatomical diagnosis.
But I want to argue for lateral video fluoroscopy. We use that all the time in cleft clinics.
We do. The patient swallows barium or speaks while we take moving x-rays.
It gives a beautiful view of the palate trying to strike the pharyngeal wall. Why isn't that the best modality here?
Because video fluoroscopy is a functional test, not an anatomical diagnostic test for an occult defect.
Ah, function versus anatomy.
Yes. The moving x-ray will show that her soft palate isn't making contact. It diagnoses velopharyngeal incompetence, or VPI.
It proves the valve is leaking.
Right. But VPI can be caused by many things: neurological issues, a deep pharynx, or this cleft.
The fluoroscopy tells you the engine is misfiring, but it doesn't let you look under the hood to see the cut wire.
Exactly. To diagnose an occult anatomical defect, you have to visualize the anatomy directly with the nasendoscope.
That is a massive high-yield concept. Diagnosing function versus diagnosing anatomy.
Absolutely crucial for the boards.
Okay, let's step into the aesthetics clinic. We have a case of iatrogenic anatomical distortion.
Always fun to fix our own mistakes, right?
Yeah. You treated a 35-year-old woman with Botox for dynamic forehead wrinkling in her central forehead and glabella.
Standard treatment.
Right, but 3 weeks later, she returns. She has a highly unnatural peaked appearance of the lateral eyebrows.
Ah, the classic Mephisto sign.
Yes, and she has some residual wrinkling in the center of her forehead when she animates.
Okay, we need to fix this.
The options are more Botox to the central frontalis, Botox plus filler, Botox to the lateral orbicularis oculi, Botox to the mid part of the lateral forehead, or just reassure her it's temporary.
Before we pick an option, we have to map out the biomechanics of the upper face.
The resting tone of the eyebrow is just a constant tug of war between elevators and depressors.
Precisely. It's all about vector forces.
The only elevator of the brow is the frontalis muscle, right?
Yeah. Yes, it pulls the brows straight up. Opposing that, you have a complex of depressor muscles.
The procerus pulls the glabella down, and the corrugator pulls the medial brows down and in.
And laterally, you have the orbital portion of the orbicularis oculi, which pulls the tail of the eyebrow downward.
So when you inject Botox, you block the acetylcholine vesicles,
Yeah.
effectively paralyzing the targeted muscle.
Yes. So let's look at what went wrong here. We injected the central frontalis and the glabella.
We paralyzed the central elevator and the medial depressors, but we completely ignored the lateral forehead.
And this creates the Mephisto sign. The central frontalis is paralyzed, so the medial brow drops slightly.
But the lateral fibers of the frontalis are completely active.
In fact, they contract vigorously because the brain is trying so hard to lift the heavy central brow.
They pull the lateral eyebrow violently upwards against the lateral orbicularis oculi.
It is a seesaw effect caused by a loss of horizontal equilibrium.
So to fix a seesaw, you have to restore the balance.
Which brings us to the correct option: administering Botox to the mid part of the lateral forehead.
Just a few units to weaken that upward vector.
Exactly. It allows the lateral brow to gently drop back down to a natural resting position.
But I know a lot of junior injectors would look at the stem, see residual central wrinkling, and want to choose option A.
To just inject more Botox into the central frontalis to smooth the last wrinkles?
Right. Why is that a bad idea?
It would be a functional and aesthetic disaster. If you do that, you will completely obliterate whatever weak elevator tone is left.
But central brow will completely crash.
You'll create profound central brow ptosis. The patient will have heavy, hooded eyelids, look exhausted, and might even struggle to fully open their eyes.
And it does absolutely nothing to fix the hyperactive lateral fibers causing the Mephisto arch.
You must treat the specific muscle fascicles causing the vector distortion.
What about option E? Reassuring her it's temporary.
I mean, pharmacologically it is true. It'll wear off in 3 or 4 months.
But ethically,
It is professionally unacceptable. You don't leave a patient walking around looking like a Disney villain for a quarter of a year when you can fix it with 2 tiny injections.
master the vectors. Don't just chase the wrinkles.
Exactly.
Let's transition from an aesthetic annoyance to an absolute surgical emergency.
Flap complications.
Yep. A woman had a breast reconstruction 6 hours ago. You used a pedicled latissimus dorsi myocutaneous flap plus a silicone implant.
Okay, pedicled LD flap.
You're on ward rounds, and you note that the flap has become profoundly engorged.
Oh, at 6 hours post-op, that is a flashing red light.
What is our immediate action? Apply leeches, explore the pedicle of the flap, arrange an ultrasound to exclude a hematoma, remove the implant in exchange for an expander, or remove the implant and return the flap to the donor site.
In microsurgery, the sacred mantra is time is tissue.
So before we act, what does engorgement actually mean on a cellular level?
Engorgement is the macroscopic physical manifestation of severe venous congestion.
A flap survives on a delicate balance of inflow and outflow.
Arterial blood pumps in under high pressure. Venous blood must drain out under very low pressure.
When a flap is engorged, it's swollen, tense, and dark purplish blue.
And the capillary refill time becomes almost instantaneous because the beds are distended with trapped, deoxygenated blood.
Blood is pumping in, but it can't get out.
Now, this is a pedicled flap. It remains attached to its original blood supply, the thoracodorsal artery and vein in the axilla.
We just tunnel it under the skin to the breast pocket.
Right. So if a pedicled flap gets profound venous congestion at just 6 hours, you have to assume there's a catastrophic mechanical obstruction of the main vein.
Because veins are thin-walled, they're easily compromised.
It might be twisted 180 degrees, it might be kinked around a fascial band, or the implant might be compressing it, or there's a thrombus.
So a mechanical problem requires a mechanical solution.
Which is why the correct answer is to explore the pedicle of the flap in the operating theater immediately.
You have to open the wound, visualize the vessels, and untwist the kink. But let me play devil's advocate. We have medical leeches in the pharmacy specifically for congested flaps.
Hirudo medicinalis, yes.
They secrete hirudin, a thrombin inhibitor, and they physically extract the blood. Why not just put leeches on the breast and save her a trip to the OR?
Because applying leeches here demonstrates a fundamental misunderstanding of the pathology. Leeches are a salvage therapy for distal venous congestion.
Like at the very tip of a flap that was designed too large.
Exactly, where the main pedicle is definitively known to be patent, but the microcirculation at the edge is struggling.
But here the entire flap is engorged, the main outflow pipe is blocked.
If you put a leech on a flap with a twisted main pedicle, it'll suck out a few milliliters of blood, but the mechanical obstruction remains completely unresolved.
And while you are watching the leech, the venous pressure inside the flap just keeps rising.
Until it exceeds the arterial capillary closing pressure, then arterial inflow stops completely.
The no reflow phenomena.
And the entire flap undergoes irreversible necrosis. You cannot fix a kinked garden hose by poking a tiny hole in the nozzle. You have to untwist the hose.
That is a phenomenal visual, and that exact logic rules out arranging an ultrasound to check for a hematoma, right?
Exactly. A massive hematoma could definitely compress the pedicle, but an ultrasound introduces a catastrophic multi-hour delay.
Waiting for the radiologist, transporting the patient.
By the time you get the scan results, the flap is dead. You bypass the imaging, go to the OR, and diagnose the hematoma by opening the incision and evacuating the clot directly. Time is tissue.
Okay, moving from acute emergencies to the terrifying long-term consequences of oncology treatments.
These cases are always sobering.
You have a 70-year-old woman in your clinic. 20 years ago, she had a right-modified radical mastectomy and extensive chest wall radiotherapy for breast cancer.
Okay, history of radiation.
Because of the node clearance and radiation, she has severe secondary lymphedema in her right arm. She is otherwise well, but takes warfarin for atrial fibrillation.
Got it.
Today, she presents with 3 new purple areas on her right chest wall. They are 1 to 2 centimeters, and crucially, they are raised.
That is a highly alarming presentation.
The potential diagnoses are angiosarcoma, Kaposi sarcoma, a lymphovenous malformation, postphlebitic syndrome, or warfarin-related ecchymosis.
What's your first instinct?
Well, seeing a patient on warfarin with purple spots, my immediate thought is just bruising. Warfarin-related ecchymosis.
It's a common distractor, but a bruise doesn't explain the 2-decade timeline.
The history is everything here.
It really is. This clinical vignette is a textbook description of a specific aggressive secondary malignancy. The correct diagnosis is angiosarcoma.
Secondary to the radiation.
Exactly. Radiation causes double-strand DNA breaks in cancer cells, but it also causes permanent sublethal DNA damage to the normal endothelial cells lining the local blood vessels.
And over 20 years, those mutated cells can undergo malignant transformation.
Especially when you combine it with chronic lymphedema, which causes localized immunodeficiency in the limb.
The immune system can't clear the mutated cells.
It creates the perfect environment for radiation-associated angiosarcoma. It classically presents as reddish-purple macules or raised violaceous nodules directly in the irradiated field.
And the latency period is usually 10 to 20 years.
Our patient is 70, treated 20 years ago at 50. The timeline is flawless.
But what about Kaposi sarcoma? When we see raised purple lesions, Kaposi is usually the first buzzword we think of.
Kaposi's can definitely present as raised purple nodules, but the etiology is entirely different. It's an endothelial tumor driven by human herpes virus 8.
And it almost always requires profound systemic T-cell immunosuppression, right?
Yes, like advanced HIV or solid organ transplant anti-rejection meds. Our patient is 70 and otherwise well.
She just has localized immunodeficiency from the lymphedema, not systemic.
Plus, Kaposi's tends to be more widespread, often involving oral mucosa or lower extremities. A highly localized presentation on an irradiated chest wall points directly to angiosarcoma.
And to address the warfare, distractor bruises are flat. The stem explicitly says these lesions are raised nodules. A bruise doesn't form a 2-centimeter tumor.
Exactly. She needs an immediate core biopsy.
Let's move to congenital vascular issues. We have a 26-year-old man in the clinic. His left leg is significantly larger in circumference and length than his right leg.
Okay, limb hypertrophy.
And on the skin of that leg, he has a large cutaneous capillary malformation, a port wine stain, and multiple atypical dilated varicose veins.
This is a classic syndromic presentation.
The exam asks to identify his major lifelong risk. Is it consumptive coagulopathy, developmental delay, epilepsy, heart failure, or thromboembolic disease?
First, we have to synthesize the findings to diagnose the syndrome.
The triad of a port wine stain, limb hypertrophy, and atypical venous malformations.
That is the pathognomonic presentation of Klippel-Trenaunay syndrome, or KTS.
Right. And understanding the hemodynamics of KTS is how we predict the complication.
Exactly. The venous anomalies in KTS are not like normal varicose veins. They are profound, deep venous malformations.
Like the embryonic lateral marginal vein of Serval.
Yes, a massive valveless vein. Because they lack functional valves, they cannot pump blood efficiently back to the heart against gravity.
So the blood pools and stagnates in the hypertrophic limb.
Which brings us to Virchow's triad: endothelial injury, hypercoagulability, and venous stasis.
Because these patients have massive venous lakes, they suffer from extreme chronic stasis.
They are at a dramatically elevated risk of developing deep vein thrombosis within these malformed vessels.
So the ultimate danger, and the correct answer, is thromboembolic disease.
Yes. If a piece of that massive clot breaks off, it causes a potentially fatal pulmonary embolism.
Which highlights why managing KTS isn't just about using a laser to fade the port wine stain for aesthetic reasons.
You are managing a lifelong hematological risk. They need compression garments, prophylactic anticoagulation during surgery, and aggressive screening.
What about option A, consumptive coagulopathy?
That is a very specific complication known as the Kasabach-Merritt phenomenon.
Which is associated with rapidly proliferating high-flow vascular tumors, right?
Like Kaposiform hemangioendotheliomas, the tumor architecture physically traps and destroys circulating platelets,
leading to profound thrombocytopenia. But KTS is a slow-flow capillary and venous malformation.
It is not a rapidly proliferating tumor, and it doesn't consume platelets. So it's the wrong answer here.
Okay, let's shift to revisional aesthetic surgery.
Complex, multi-vector planning.
You have a patient who had bilateral breast augmentations 15 years ago. Smooth, round silicone implants, subglandular plane.
Over the muscle. Okay.
Her breasts are now highly asymmetrical. She has a Baker grade 3 capsular contracture on the right breast and a Baker grade 2 on the left.
Okay.
Her upper pole pinch test is 1 centimeter, indicating very thin tissue, and her nipple sit exactly 1 centimeter below the inframammary fold on both sides.
So we have capsular contracture and significant phantosis.
The exam gives a long list of surgical options involving combinations of unilateral or bilateral exchanges, capsulectomies, and mastopexies.
To find the correct plan, we have to dissect the biology of the capsule first.
The definitive correct plan is bilateral capsulectomies, bilateral mastopexies, and bilateral reaugmentation with new implants.
Let's break down why. Every breast implant generates a foreign body response.
The body walls it off with a scar tissue envelope, the capsule.
Normally, it's thin and soft, but over 15 years, myofibroblasts can become hyperactive, lay down dense collagen, and contract.
Let's review the Baker scale quickly.
Baker 1 is normal and soft. Baker 2 is slightly firm but looks aesthetically normal.
And Baker 3.
Baker 3 is firm, and the contraction physically distorts the shape of the breast, often pushing it unnaturally high. Baker 4 is distorted and painful.
Our patient has a Baker 3 on the right. That breast is hard and visibly distorted.
You cannot just massage a Baker 3 capsule, and you cannot just pop a new implant into the same rigid pocket.
You have to do a total capsulectomy.
You must surgically dissect and remove the entire fibrotic scar tissue shell. That dictates the first part of our plan.
Now the second part. The nipples sit 1 centimeter below the inframammary fold.
That defines clinical breastatosis, or drooping. Her skin envelope is stretched.
If you just do a capsulectomy and place a new implant, what happens?
You cause a major aesthetic disaster called the waterfall deformity, or Snoopy dog deformity.
The implant sits high on the chest, and the loose breast tissue and nipple literally slide down and hang off the bottom.
Like water flowing over a cliff. To prevent this, you must physically alter the skin envelope.
Remove the excess skin and reposition the nipple higher. That's a mastopexy or a breast lift. So we need a capsulectomy for the right breast and a mastopexy for the drooping skin. But why bilaterally?
The left breast only has a Baker 2 capsule. It's just slightly firm, not distorted.
Could we just leave the left implant alone and only lift the skin?
In aesthetic breast surgery, symmetry is the ultimate goal. If you have a brand new implant on the right and a 15-year-old implant with a mild contracture on the left, the breasts will look, feel, and age completely differently.
Plus, 15-year-old implants are at high risk for occult rupture.
Leaving it in situ during a major revisional surgery is a disservice to the patient. You must do bilateral capsulectomies, mastopexies, and exchange to ensure tissue matching and longevity.
Comprehensive vector management. Let's move on to pediatric lumps, bumps, and skulls.
Let's do it.
First scenario. A 2-month-old child with profound scaphocephaly and a prematurely closed anterior fontanelle.
Okay, scaphocephaly.
What is the most helpful investigation? CT head, fundoscopy genetic testing, MRI head, or plain skull X-ray?
Scaphocephaly literally translates to boat-shaped head. It is the pathognomonic sign of sagittal craniosynostosis.
The sagittal suture runs down the midline of the top of the skull.
Yes. When it fuses prematurely, the skull is physically blocked from growing laterally, side to side.
But the infant brain is doubling in volume.
So it forces the skull to grow excessively at the open coronal and lambdoid sutures. The skull elongates massively from front to back.
We know the diagnosis clinically. The investigation is to plan the surgery.
Right, and craniofacial teams try obsessively to avoid radiation.
So why not an MRI? Zero radiation, stunning brain images.
An MRI is undeniably superior for evaluating soft tissue, but craniosynostosis is fundamentally a disease of the calvarial bone.
It doesn't show the bone detail well enough.
Exactly. It does not provide the crisp, bony detail required for surgical planning. We need to map out the fused suture, the open sutures, and the underlying venous dural sinuses.
A high-resolution low-dose CT scan with 3D volume rendering provides a perfect topographical map.
The surgeons use it to plan millimeter-accurate osteotomies for complex cranial vault remodeling. The structural data makes the radiation exposure medically justified.
What about a plain skull X-ray?
It collapses a complex 3D structure into a flat 2D shadow. It lacks the dimensional data needed for multi-vector planning. The 3D CT is the definitive tool.
Next pediatric case. An 18-month-old girl with a 10-millimeter subcutaneous lump in the midline of the proximal nasal dorsum.
Right on the bony bridge of the nose.
Present since birth, hasn't changed. Smooth, hard, immobile. Overlying skin is perfect. And crucially, there is absolutely no punctum or pit on the skin.
The parents are very keen to avoid surgery.
What's the next step? MRI CT, ophthalmology, reassure and discharge, excision, or genetics.
A midline nasal mass triggers alarm bells for a nasal dermoid cyst.
Because they can be dangerous due to fetal development, right?
Yes, a projection of dura extends down into the nose and retracts. If ectoderm gets trapped, it forms a cyst,
The great fear is a patent sinus tract communicating with the intracranial space.
which can cause fatal meningitis. So many junior surgeons immediately order an MRI.
But the correct answer is to reassure the parents and discharge the patient. How can we do nothing without an MRI?
Because you synthesize the clinical exam with the risks. The lump is stable for 18 months. The skin is pristine, meaning no active tract infections.
And the paramount finding, no punctum.
A punctum is a small dimple, often with a hair. Its presence is the clinical hallmark of a sinus tract extending deep.
So no punctum means it's almost certainly an isolated superficial cyst.
Exactly.
Yeah.
And getting an MRI in a healthy toddler requires a general anesthetic.
Subjecting a toddler to anesthesia purely for defensive screening when the exam is benign and parents want to avoid intervention is poor judgment.
Reassure, discharge, and tell them to return if it grows or gets red.
Our final pediatric case, an 8-week-old baby girl with a massive 10-centimeter vascular lesion in her perineum.
A highly problematic location.
It's rapidly proliferating, ulcerated, and bleeding profusely. Excision is anatomically impossible. A biopsy shows dense mast cells, and it is GLUT1 positive.
What's the next step? Excision, NY-egg laser, observation, oral propranolol, or sclerotherapy.
Let's start with the biopsy. What does GLUT1 positivity tell us?
GLUT1 is a highly specific marker. If a biopsy is strongly GLUT1 positive, it definitively confirms the diagnosis of an infantile hemangioma.
It completely rules out other vascular malformations.
Right. Now, infantile hemangiomas usually proliferate for months and then slowly involute over years.
Since it will eventually shrink on its own, we can't excise it. Why not just observe it?
Because you must consider the anatomical location and current complications. A massive tumor in the perineum is subject to constant friction and diaper contamination.
Perineal hemangiomas have a spectacularly high rate of ulceration.
It has already ulcerated and is bleeding profusely. It risks massive infection or destroying the sphincter. You cannot observe this. You must intervene medically.
Which brings us to oral propranolol. A non-selective beta blocker is the first-line standard of care. How does a blood pressure med shrink a tumor?
It operates on 3 timelines. Immediately, it causes profound vasoconstriction, reducing blood flow and controlling the bleeding.
And over the medium term?
It blocks proangiogenic signals like VEGF, starving the tumor of new blood vessels.
And finally?
It triggers apoptosis cellular suicide in the endothelial cells, forcing the tumor to rapidly accelerate its involution phase. It's highly effective and targeted.
All right, final stretch. Maxillofacial trauma and oncology.
Let's wrap this up strong.
A patient is in the trauma bay with severe facial injuries. You note midface crepitus, visible facial lengthening, bilateral epistaxis, dense infraorbital paresthesia, and subconjunctival hemorrhage.
Which fracture pattern is this? Lefort 3-3-3 nisothymoidal or orbital blowout?
In 1901, René Lefort dropped cadaver heads to map out fracture lines. His classifications still dictate management.
The diagnosis here is perfectly encapsulated by a Lefort-Steffen fracture. It's a pyramidal fracture.
Where does it break?
It starts high at the bridge of the nose, courses down through the medial orbital wall, crosses the orbital floor, and breaks through the inferior orbital rim,
Then it travels down the anterior maxilla and backwards to fracture the pterygoid plates.
detaching the central maxilla from the skull base.
Let's map the symptoms. Bilateral infraorbital paresthesia.
The infraorbital nerve exits the anterior maxilla. The fracture line runs right through it, causing profound cheek and lip numbness.
Bilateral epistaxis.
The fracture violently disrupts the entire nasal complex, tearing the vascular plexus.
And the midface crepitus and facial lengthening.
When you rock the maxilla, the central pyramidal segment moves independently. The grinding bone is crepitus,
Because it's detached, gravity and muscle pull drag the midface downwards.
creating the classic donkey face deformity. The Lefort 2 pathway perfectly explains every symptom.
Our final oncology scenario. An unfit 72-year-old male with a history of T1N0N0 squamous cell carcinoma of the tongue, treated with full radiotherapy.
Okay, heavily irradiated tissue.
He now has a persistent, yellow, painful slough in the treated area that hasn't improved in 2 months.
What is the most appropriate next step? Biopsy, monitor fortnightly, fluconazole, hyperbaric oxygen, or review in 8 weeks.
Radiation wreaks havoc. causing hypoxia and endarteritis obliterans.
It leads to severe radiation mucositis ulceration that looks identical to a fungating cancer recurrence.
So how do we know the difference?
The deciding factor is the timeline. Acute mucositis is expected, but once radiation stops, it should slowly start to heal.
If a painful, sloughy lesion in a previously irradiated field shows zero improvement after 2 full months, your suspicion must go through the roof.
You cannot assume it's benign radiation damage. The risk of a radioresistant carcinoma or rapid recurrence is terrifyingly high.
So observing it for another 8 weeks or monitoring it fortnightly is medically negligent.
It risks missing a surgically salvageable recurrence. Fluconazole is for fungal infections, and hypobaric oxygen is a treatment for osteoradionecrosis, not a diagnostic step.
The only safe answer is to biopsy the area.
Yes. Multiple deep biopsies from the margins to capture viable tissue. It is the gold standard arbiter between benign necrosis and deadly recurrence.
We have covered an immense amount of ground today. Thank you for joining us on this intensive FRCS mock exam deep dive.
I want to leave you with a final thought to mull over. Notice a recurring theme today.
What's that?
Many of these board questions are not just testing if you've memorized the pathology. They are testing the maturity of your clinical judgment.
Testing if you know when to intervene.
Exactly. Knowing when to sprint to the operating room to untwist an engorged flap versus having the confidence to safely do absolutely nothing with a stable nasal dermoid.
The hardest part of surgery is often knowing when not to operate.
Absolutely true.
That is incredible insight. Remember to head over to medsynclimited.com to turn your reading into active recall with the ANKI deck. Keep studying, trust your clinical exams over the machines, and we will see you on the next deep dive.